Opportunity to just present this topic. Thanking the organizing committee and the team members for giving me this opportunity. So basically, food tantrums is the commonest presentation which we will be meeting every day in our OP session. Like the mothers might step in for various reasons, like it could be a viral infection or an upper respiratory infection, like could be loose stools or gastroenteritis. Whatever they are presenting to us, definitely there will be a reassurance point, or the mothers questioning us like whether my child is eating well, how am I be so sure that they are having or taking their food in the right quantities. And these are the questions which every day in our day-to-day practice we'll be facing. Before understanding what is a food tantrum will look like, the observable behaviors of a food tantrum will be like the child might be pushing the food or spitting the food or vomiting the food, or even sometimes like if any of us have an experience of feeding a child, we could have undergone the experience like even for the next spoon, the child will not open the mouth, and we really need some coping mechanisms to navigate those tricky situations. How I can modify this behavior, or how I can take my child from here to a happy feeding or eating. So before understanding food tantrums, let me just first start with the temper tantrums. So temper tantrums are nothing but unplanned outbursts. Like you can't just predict when the child will be giving the tantrum. So it's pretty unplanned, right? And the age is between 2 to 4 years, or between 1 to 4 years, you would be seeing these tantrums. And by the 4th or 5th year, basically, actually, the child might settle down if it is not having any of the biological or organic causes. Organic causes would be like autism spectrum disorder or a typical hyperactive kids. If we don't have an organic cause, then it's a neurotypical development, but tantrums can be seen even in neurotypical. So that's what I am trying to say. And the causes might be like for a biological reason of hunger, tiredness, attention, even to get your attention, even if they want something. Not all neurotypically developing children will have a functional communications or to ask like what they want, right? They might be developmentally delayed even on a communication part. So at that point, if they are not able to communicate what they want, this might be seen as a tantrum. So observable behaviors, how would you say that this is a tantrum is, you could see that the child is whining, crying, shouting, kicking, hitting, pinching. So all these observable behaviors should direct us to think that my child is going through something which is a need-based. And if I'm able to interpret the need and navigate, things can be sorted out really very positively between the mother and the child. So coming to food tantrums. So whatever I talked about the temper tantrums, actually it's now related, the entire picture can be now related to the topic of food, right? The only difference is you could see these observable behaviors of crying, shouting, or pushing typically happening at your dining table. So the only difference is it happens for a food on the table. So the child could push the food, or it could run from the dining table, or it could spit the food. It could even vomit the food. As I told you, like it might even close its mouth, like not allowing you to feed further. So most of the parents, like being a pediatrician and being a parent, most of us would have gone through this between 2 to 4 years. And most of the mothers like who come to our clinic, like especially when the child is having a, basically if the child is having a food tantrum and the child is presenting to you with some amount of organic illness like a upper respiratory infection or a gut or a gastroenteritis, the food tantrum will be felt more. So during the infection, the behavior actually will escalate, basically. So that is a real point. How am I going to feed or give the nutrition which is even necessary during the illness? Because during the illness, we need to feed more. So we need a better cooperation from the child. So at that point, this is the reason why we want to address. Why should we talk about this food tantrums is the significance of how much it might affect the immunity, the calorie, the nutrition intake. So that's where the significance of the topic comes. So why should we address? If the child is having repeated tantrums, and we are not able to find a solution or navigate, definitely this child is going to land with a calorie or a nutrition deficit. And in long course, if this is going to continue for a span of time, or if this is going to take it for a longer chronicity, so we are going to see something which is termed as failure to thrive, which all pediatricians we are familiar, FTT. So it is better to go for an early intervention. Early intervention here means early behavioral intervention, and early behavioral intervention in the context of food tantrums, right? So what is the term which is meant by picky eating is the commonest term which is used in our science. Picky eating means the child refuses food often and eats some food over and over. Sometimes most of the mothers like 9 by 10 might be presenting like, ma'am, how can I make my child eat better, like that. 1 by 10 of mothers, they will tell, சாப்பிட வைக்கிறது எனக்கு பிரச்சனையே இல்லை. Like she'll be very happy, right? And that means that is a core area where every parent as such, they feel complete like enough food is being taken and yes, the immunity is looked upon. So picky eating is the child might refuse the food often or eats the same food over and over. Eating the same food will not fulfill the balancedness. So definitely there will be nutritional deficits of some amount of micronutrients or something on that area. So the food selectivity needs to be intervened very early so that when they grow up into adolescence, they really have a beautiful food habits and the health which is radiating from them. So the term of food aversion disorder was coined after studying a lot of children with this sort of food refusal behaviors. So this is seen in children with chronic medical problems. So we would have seen a lot of children, maybe it is a malignancy for which a childhood malignancy which is representing, or it is a chronic nephrological issues where the child would represent to the ward or take treatment or visit hospitals continuously. They are chronically visiting hospitals and a very young age. Sometimes even for a preterm or more of NICU care. So those children also will need a periodical follow-up, like it's a consistent thing which is going on for a longer time in their life. So those children who are on intravenous nutrition continuously, on tube feedings, who are breathing with ventilators, or could be an pneumonitis which is taking a longer time to heal and they need a lot of support systems. So these children, when they come out of this particular period, they might land up in something called food aversion disorder. There is another term which is known as avoidant or restrictive food intake disorder. Here, though there are no biological reasons or organic reasons or no chronic admissions into a hospital or tube feeding, we do say there is something called oral sensory issues. The oral sensory issues are particularly represented by a field called occupational therapy. So the oral sensory issues means the child has some hypersensitivity. So because of that, the child is not able to accept certain textures of food. For you, it is convenient, but for the child, it is more sticky. So the textures or the smell, it is like aversive for the child. So that particular sensory area should be represented. We should team up. The pediatrician should team up with the therapist. There are tests where we would measure or scale up what would be the hypersensitivity level, and normalizing the sensory level would be the answer for making the child to get exposed to more number of food. And if the intervention is done earlier, we are laying the foundation for a future healthy food habits. Just locating, oh, this is oral sensory. So just giving the sensory interventional area would create a lot of turnover from that point to the food acceptance curve for that particular child. So this is absolutely a teamwork where the pediatrician, they identify the concerns of the parents, they represent to the parents' concern, and the behavioral analyst comes here and they see the observable behaviors. Once we see the observable behaviors, we hypothesize why these behaviors, anything has a cause. So we go to the hypothesis or arriving at the function of the behaviors. We actually do a frequency or measure the behaviors, chart the behaviors, then we address the hypothesis basically. Then we create the program which actually reduces the frequency of these behaviors. And this is actually a smooth journey for both the mother and the child from here. And is your child eating less? This is a question for us. Where is the norm? So how can we give a norm for this? So whether it is a concern or whether it is just needing a reassurance, how do we discriminate whether the child is taking enough and growing enough? So we need to look at their height and weight lines in the traditional centile charts which are available for every pediatrician. And we will be probably finding that they are growing as they should be. If that is the thing, we can reassure. If that is not the thing, we can actually step in, we can guide them, we can hypothesize the reason for this feeding or aversive behavioral pattern. We can create a program and we can start the interventions which would actually direct us to a beautiful journey from there on. So when do we advocate for assessment? So where do we draw the line? This is going to be just a reassurance, or when do I really need to take it in the assessment form and guide from there? So when the child is not gaining enough weight as per the normative percentile charts, when the child is not developing normally, like visiting the clinic often, like the number of respiratory infections is really high, the immunity is really like need to be addressed. So these would help us like having the hemoglobin or looking at them. So all these variables or the parameters will direct us telling, oh, yes, this is the time where the child merely needs beyond something a reassurance, where they have to step in for an assessment. So just ask the history of whether there are coughs, chokes, any gagging, any vomiting during feeding. And these behaviors actually, they are also risk for aspiration. So it is just the need to be getting into the history point and addressing these different forms of behaviors. Actually, all these behaviors are leading to us to something called the refusal. So the waiting norm, how long can I wait and how can I fast get into an assessment? So some infants refuse to take food when they are first introduced to any solids. Till then they'll be having a liquid foods, and there's something, a small line from where we shift from the liquid point to the solid point. And sometimes if they refuse, it is absolutely okay for us to wait and reassure the mother that you can wait for 1 or 3 weeks and reintroduce. Maybe they're not ready. And it's never the same. Each child is different. Each child's developmental curve is different. So not all children will be ready to begin solids at the same time. So let us wait for some time, then go for assessment. So the need for thorough evaluation. So the role of pediatricians for thorough evaluation is the need of the hour now. So we need to represent this in our OPD practices. And a thorough evaluation might help the mother to understand what is actually. So understanding the behavior is the whole principle of the science. So why is this behavior occurring will help me to guide to the cause and address me to the cause of the behavior, then help me to write a positive intervention. Simple interventions like when the child is giving a lot of positive behavior on the table, we need to reward the child. Instead of like, we are giving more attention to the negative behaviors which are happening on the table. But a small shift, why don't we give more attention to the positive behaviors and the reward to the positive behaviors? So it's as simple as that, the strategies which can be carried home by the mother instead of being working in a clinic. So simple strategies. So to integrate and team with the speech and occupational therapist if we are to address some oral sensory issues. So diagnosing, so swallowing difficulties could be a reason, chewing difficulties could be a reason, gastroesophageal reflexes, medical reasons, biological reasons, achalasia, which is very, very uncommon, but still it could be the reason, even if it is less than 1%. So how do we diagnose this? We can give barium with different consistencies. The child is given barium with different consistencies to drink, and the x-rays are taken periodically, and look for whether the barium is swallowed or aspirated. So the medical reasons for the food refusal needs to be addressed and needs to be evaluated, needs to be investigated before getting into the behavioral diagnosis. So the medical reasons from the pediatric side could be, it could be a dysphagia, difficulty in swallowing, gastroesophageal reflex where the child could spit up, and constant spitting up and reflex can lead the child to esophagitis, which is in turn very painful for the child. So when something is painful, definitely the refusal behaviors are seen observable from the child. So oral motor dysfunctions, we have a lot of oral motor muscles, inclusive of the buccal muscles, the tongue, the movements, everything over there. So do we have a functionally integrated oral motor functions which is happening here? So the neuromuscular disorders, which could be cerebral palsy, SMA, spinal muscular atrophy. So those would be the muscular causes where the child is not able to give the enough muscle to even swallow. So obstruction, where there is a delayed gastric emptying and there would be a GIT obstruction. Achalasia is very uncommon, but still it could be the last resort where we would rule out a medical reason before concluding or writing or thinking in terms of a behavior. Therapists are part of early childhood intervention. This is purely like it's a teamwork, and where a lot of speech therapists and occupational therapists, they even go when the X-rays with the barium is done. Actually, it is done in some countries, like where the therapists are standing by the side when the test is done, and it is really addressed like this way. So the team will observe how the child is swallowing and how the attempts to swallow foods of different consistencies are taking place. This clear observation will guide us to the next level of concluding or writing a program for the child. So food refusal behaviors can be seen. If you could see these behaviors, if you could observe these behaviors as any of the children, it is of concern. The child turning the head, the child spitting out the food, the child holding the food in the mouth. So most often, some of my mothers, they have told this in my clinic, like they're holding the food and we are not even able to keep the next spoon. So this is a particular thing which I have heard like from my mothers. So refusing to open the mouth. So it is literally the child is not able to give a cooperative behavior. When you place something, you need such cooperations to travel with the child. So aggression, some children might even land in aggression. By the time the mother is starting to take the cup, or the child is understanding, oh, the food is coming, the child starts showing even aggression or running from the place, or even injury. Some injurious behaviors could be done for themselves. So these are the things which are indicating that the child is resorting to some refusal behaviors, and these behaviors are observable. So one thing is we could just observe those behaviors. This is a particular picture, and I think as parents, we could have witnessed this at some point of our life, even sometimes during infections. Neurotypically, a child who's taking food very normally also, when they go through with some medicines or with some illnesses, we could witness such behaviors. Those 2 or 3 days, it's really difficult for us to go with the child. So what is the best time to introduce the solid foods? Would be 6 to 10 months. That is the best time. So that is a time because the oral motor skills are getting developed at that time. So if it is not developed also, there are so many various functional plays or programs which are coming now, where we can pre-skill, like we can do a oromotor pre-skills, where the child could be able to process the food when it is introduced, like so that it is smooth for both of us. When this step is delayed, like we are not going to introduce like 6 to 10 months, we are going to continue with the child, because sometimes the mother introduces, the child shows some behaviors, the mother withdraws, again after a few weeks the child is introduced. And if this is going to be delayed at this point, the more the delay, the more the refusal behavior starts. And this is the time where we could support the community or mothers, so that we could see a community with more health and more nutritional aspects. So what are some natural strategies, take-home strategies as a pediatrician for me when these questions are given to me? So most of the time, the meal times are looked upon like, oh, it is like some of the exam times are looked up at some of the houses, like, oh, how far you have read, how far you have completed. Beyond those way of responding to a child, can we do a beautiful pairing at the table? Pairing is something connecting with your child. So it is not that you have to eat, or how much you have to eat, you have to finish the plate. Beyond giving those target goals, let us start with pairing and connecting, which happens very naturally. Oh, how was your day? So what was your teacher? How did your teacher talk to you today? So what was the lunch you had? So what was the play which you did? So these are some things which are to and fro conversation, which would be beautifully, you can start the dining table with a beautifully connecting and a conversational pattern, instead of just thinking what she's going to have, how much I can feed. All those things can take a little behind. So we start with connecting, and at least put one thing. There will be some preferred food for every child. So make the plate attractive, like give one preferred food, and once the preferred food is done, they will move on to the non-preferred food, can be paired along with the preferred food. Continue to expose them to new food. Exposure is the key here, because we keep continually exposing them. The more the exposure, the more the graded exposure which is happening for the child with different environment, different food and different cuisines, your child is going to get adapted to a better food in long due. So give attention for good meal times and not only to bad meal times. Make sure that they get exercise so that they have enough appetite to move on. And it's absolutely normal for kids to prefer certain foods. Even as adults, we prefer certain foods and textures. But modeling good eating behaviors is taking the non-preferred food also along with the preferred food. Like parents can model, grandparents can model, and that's what the earlier joint family, like there was a lot of modeling happening for the child going on in the family. So the modeling actually helps them to overcome food selectivity. So food selectivity is this: you will have certain preferred foods and you will have certain non-preferred foods. So coming to the science of ABA, how it helps. So the science of ABA is applied behavioral analysis. It is a scientific approach. Here we understand the behavior. So how do we understand the behavior? So ABA refers to the set of principles that focuses on how behaviors change or how behaviors are affected by an environment, right? So there is a causal relationship between environment and behavior, as well as how learning takes place, because the environment influences the behavior. Definitely, there is a causative relationship. Any behavior which is rewarded definitely will occur in future frequency. We will see an increased frequency. That is the learning which happens on the any behavioral curve. So this is like a research paper given by Casey and Perrin. So they have done a research where they have applied ABA principles and they have increased the by accepting and reducing food refusal in a child with autism. A rare study, and it's a long-term follow-up, and it demonstrates successful remediation of food refusal behaviors. Reward techniques is which can be used. And to conclude my topic, this is an inspiration. He is Cian Cassie. He is a board certified behavioral analyst. He is a chief clinician and clinical director. He is a nationally recognized expert in the field of children's feeding disorders. And Dr. Casey has developed one of the few programs nationwide that works directly and intensively with families and their children in their home where the feeding disorders occur. Every meal, every day. So it was a beautiful community reach which he has designed, an inspiration to take home. And I thank each one of you for giving such a dedicated listening. And I conclude my topic. Thank you, ma'am. Thank you, everyone.
Thank you, Dr. Vinodhini, for excellent presentation. For the benefit of our delegates, I just want to add few points. Parents always should test the food. Sometimes mothers should test the food. Sometimes they don't add salt. The food will not be tasty.